Hello everyone. Today I'll be starting by talking about the orbital apex. I asked before, what is the red bone outline in the skull base? It is the sphenoid. The sphenoid is the most complex bone in the skull base and maybe in the entire body. It really holds the skull together and has many complex features. Here we see it looking from above. This is looking at the sphenoid bone by itself from the front, and this is looking from the back. As you can see in this diagram of the sphenoid bone looking from above, there's a tremendous amount of structures in the sphenoid bone, and we will just focus on a few of them today. The rest of the structures I'll cover in some other talks. What I'm going to focus today is the structures of the orbital apex, the optic canal, the superior orbital fissure, which is not well seen on looking from above, and the anterior clinoid. Now, if we look at a CT, an axial CT, we can identify the anterior clinoid and the optic canal. As you can see, anterior clinoid and optic canal. Now, the superior orbital fissure is much better seen on this coronal view of the sphenoid bone looking from behind. So again, the optic canal, the anterior clinoid, and the superior orbital fissure, which has a elongated shape, as you can see here, much larger than the optic canal. So if we look at axial CTs, we can see the superior orbital fissure at different levels. Again, medially is the optic canal, the anterior clinoid, and then more laterally is the superior orbital fissure. At the coronal view, we can see, just like on this specimen looking from behind, here's the optic canal, the anterior clinoid, and the superior orbital fissure. And we can see on the CT, the optic canal, this is the anterior clinoid, and here's the superior orbital fissure, just slightly more anterior. Because the greater wing of spheno is very thin here, we will occasionally see not the entire outline of the superior orbital fissure. And again, here it is on the axial. Now, another important structure in the orbital apex is the optic canal and the optic strut. The optic strut forms the floor and the lateral wall of the optic canal and separates the optic canal from the superior orbital fissure. And if we look at this picture of the optic canal looking into the orbit, we can see the optic strut separating the optic canal from the superior orbital fissure. Here it is looking from behind, from inside the skull, optic canal, anterior clinoid, and the optic strut between the optic canal and the superior orbital fissure. And here on the CT, optic canal, anterior clinoid, and superior orbital fissure. We can identify the optic strut, which is a very tiny bony structure, on the axial plane, just inferiorly to the optic canal, and also on the coronal plane between the optic canal and the superior orbital fissure. Above it is the anterior clinoid, and on the sagittal plane, this is a specimen showing the optic strut below the anterior clinoid, and here it is on a sagittal CT. Sometimes the optic strut is pneumatized, like an extension of the uh, sphenoid sinus. Here is pneumatized on the axial plane. Here it is on the coronal plane, and we can even see it pneumatized on the sagittal plane, this being the anterior clinoid. Sometimes the pneumatization extends even into the anterior clinoid. So here are two pneumatized anterior clinoids, and here's the pneumatized optic strut. One of the things which we should be alerting the clinician is when one of the septa of the sphenoid sinus end in the optic canal, because if they're going to do fast surgery, they have to be careful not to damage the optic nerve if they follow the septum towards the optic canal. So again, optic canal medially, laterally is the anterior clinoid. We can also identify these structures on a coronal MR. Here's the optic canal, the optic strut, and the anterior clinoid. Again, on CT, optic canal, clinoid laterally, and the optic strut on the specimen as well. Canal, clinoid, optic strut. This is an unusual case of a very specific fracture following trauma involving the optic strut. You can see the break here. Here's a normal optic strut, and we can see on the axial plane, here's a little piece of bone which came off from the part of the optic strut that was broken off. Very unusual fracture involving the optic strut or the floor of the optic canal. We can, again, identify these structures. Here's a patient who had an optic nerve meningioma. And I want to point out on the specimen here, this is the clinoid optic canal. Remember, the optic canal with the nerve within it is always medially to the anterior clinoid. Again, on the coronal CT, clinoid, optic canal. On the patient, we can see, look at this is the cortex of the right clinoid. This clinoid is much larger, the cortex is a little thicker because of the hyperostosis secondary to the meningioma, which is enhancing within the optic canal. Much larger clinoid compared to the opposite side. Now, we have the full view of the structures of the orbital apex. On this coronal MR, we have the optic canal, the superior orbital fissure, and again on the CT, optic canal, clinoid, superior orbital fissure. Remember that the superior orbital fissure should have fat within it. You see some structures like nerves and blood vessels. So it should be a bright structure and normally. Now, why is the orbital apex important? That is, the structures of the optic canal, superior orbital fissure, and the anterior clinoid process. Because a number of nerves go through these structures. The optic nerve, the oculomotor nerve, the trochlear, the first division or the ophthalmic division of the trigeminal, and the abducens nerves. And if you remember from my last talk of the cavernous sinus, here are all these nerves within the cavernous sinus. On the coronal view, the third nerve, the fourth, the sixth below the carotid, and then V1 and V2. And as I demonstrated, we can identify these nerves on a coronal MR. However, only some of these nerves from the cavernous sinus will proceed through the superior orbital fissure and the optic canal. In this diagram, we see again the trigeminal nerve in a sagittal view. So here we have the ophthalmic V1. This is the maxillary nerve going to the foramen rotundum, and the mandibular nerve going through the foramen ovale. We're going to just focus on the first division, the ophthalmic nerve. It actually breaks up into its various components before it enters the superior orbital fissure. Other nerves going through the superior orbital fissure are the oculomotor nerve, goes through the superior orbital fissure, the trochlear nerve goes through the superior orbital fissure, and the abducens nerve. So if we look at this diagram of the orbital apex, we can see the complexity of this region. Here we have the large optic nerve and the ophthalmic artery, which I'll demonstrate again. And then we have all these various nerves going through the superior orbital fissure. Two divisions of the third nerve, the sixth nerve, the fourth nerve, the ophthalmic vein, and the various branches of the ophthalmic nerve. And the European, again, Dr. Castleman has demonstrated, for instance, here's the optic nerve, and we can see the third nerve. So you can see some of the structures, but it's not easy to separate them. Now let's talk about, can we visualize the optic nerve and the ophthalmic artery within the optic canal? Again, to get a good view of the optic canal, you have to angle the specimen and also do oblique reformats. If you look at this skull here, I put some pipe cleaners through the optic canal, and you can see that the optic canal has an infra-anterior type direction, so you have to turn it a little bit and also reformat the images in a slight angle to see through the optic canal. Now I want to point out this relationship here. We're looking here from above at a dissected specimen. This is the sella turcica with a diaphragm cella. We're looking from above. The dorsum is here. These are the two optic nerves exiting or entering the optic canals. And we see this is the carotid artery coming out of the cavernous sinus. And these are the ophthalmic arteries entering the optic canal below the optic nerve. And again, the two clinoids on either side. So if we look at this beautiful reformatted oblique coronal CT that Kathy did, we can see how similar this anatomy is to the specimen here. So here's the optic canal, and this is part of a contrast CTA, and we can see the ophthalmic artery, we see the optic strut, and the anterior clinoid over here. So again, just like in the specimen, optic canal, strut, and anterior clinoid, except that here we see the ophthalmic artery. And here's a coronal MR of the same region, of the orbital apex, and we can see the optic nerve within the optic canal, and we see the enhanced ophthalmic artery bilaterally, and this is the superior orbital fissure, and we can see the dark anterior clinoids on either side. So we can identify on MR the optic nerve and the ophthalmic artery, as well on CT we can see the ophthalmic artery on the CTA. Now sometimes there are anomalies where the ophthalmic artery arises from the carotid. Normally it'll arise as from the top of this upper curve, but sometimes it will come off a little more inferiorly, like almost within the cavernous sinus. And a study I did many years ago of the development of the optic canal shows that the optic canal early in fetal life has this kind of keyhole shape, and progressively it develops this round appearance as the optic strap enlarges during embryonic development. Sometimes, however, there's an anomaly where instead of a single optic canal, there's a split optic canal with a superior component for the optic nerve and the inferior for the ophthalmic artery. And we can see here on these fetal specimen, here the ophthalmic artery is going to enter below the optic nerve, but here it's a split canal with a separate canal for the optic nerve, and the ophthalmic artery enters below, just like in this specimen. I have not seen that yet on a CTA, but I would be happy if somebody could find a case and give it to me. Okay, what is the abnormality in this image of the both orbital apex? Which side is abnormal? Correct. As Dan and Ben and Anshu, everybody picked the right side. That's all correct. Notice on the normal left side, you see fat. This is all opaque here. And the reason for that, this patient had an adenocystic carcinoma that is known to invade and follow many nerves. So again, notice on the normal, that's what you should see. On the T1, you should see a bright superiorbital fissure. This is all is obliterated because of the invasion by the adenocystic. Which side is abnormal here? Again, it's the right. Notice all this tissue over here, and a common condition. This was a 15-year-old with non-Hodgkin's lymphoma, presented with proptosis, and we can see the involvement of the cavernous sinus, but look how it extends into the orbital apex here. That's why the patient had proptosis. Notice, by the way, on the opposite side, this is the third nerve, which is sometimes seen when there's marked enhancement. This was another case. Here, the abnormality is on the left side. This was a meningioma involving the cavernous sinus, but also notice it extended into the orbit, involving the orbital apex. What is the abnormality here, and what is the condition? Anybody? Correct, as Ben and Asif said, the right side. What is the possible condition? Possibly meningioma. Anything else? Lymphoma, somebody mentioned? Anything else? Correct. As Dan mentioned, pseudotumor. This is a case of orbital pseudotumor. And again, I just want to point out how well we see the cortex of the clinoid, the optic canal with the nerve, and clinoids. Remember that the optic canal is always medial to the clinoid. And here we see the enhancement in the orbital apex, and this is a classic finding sometimes for orbital pseudotumor. Here's another patient. Patient presented with a dilated pupil and eye pain. Which side is abnormality in? Somebody mentioned the left. Notice there's a little bore. Notice this is a tough case, but notice there's this normal high signal from the veins on this side. This is again grayed out a little bit here. The abnormality again was actually on the right side. Patient had dilated pupil and eye pain. And this again is a case of orbital pseudotumor. Again, minimal enhancement, but there is enhancement in the orbital apex. This is a patient with a right third nerve palsy. What's the diagnosis here? Notice the involvement of the orbital apex. This is Toulouse-Hunt syndrome. Again, to review, Toulouse-Hunt is a nonspecific inflammation within the cavernous sinus superior orbital fissure and orbit. Severe pain are the symptoms of ophthalmoparesis, pupillar dysfunction, paresthesias of the forehead. It relates to the histopathology of pseudotumor and has the same imaging feature, except, and this is the case here, the Toulouse-Hunt has paresis of the extraocular muscle. So that's the difference between Toulouse-Hunt and orbital pseudotumor. And again, here's a patient had inflamed peripheral right eye with the sixth nerve palsy. That would make it a Toulouse-Hunt syndrome. And again, notice the abnormal enhancement here in the region of the superior fissure, orbital apex. Also note the enhancement here, but notice also there's a little bit of enhancement around the optic nerve here. So there's a little bit of enhancement around the nerve, and also the marrow within the clinoid shows a little bit of enhancement compared to the opposite side, and significant enhancement within the superior orbital fissure, and we even see here the third nerve again. So Toulouse-Hunt. This was the case I showed last week of Toulouse-Hunt, showing the marked expansion here at 4 weeks, and after 9 weeks of treatment, the tumor mass markedly reduced in size. This was an unfortunate young patient. They had a nasopharyngeal carcinoma that we can see here, and had perineural spread to involve the orbital apex. As you can see here, loss of the enhancement of the veins within the cavernous sinus and the orbital apex, and extending into the orbit. So this is orbital apex disease of a nasopharyngeal carcinoma, which started in the nasopharynx. In this case I showed before of idiopathic hypertrophic pachymeningitis, showed all the severe involvement of the tentorium posteriorly, and also the IAC, and within the orbit. And again, this is the case that I showed, shows the involvement of both the orbital apices, again, the ophthalmic artery within the optic canal. Okay, what is the abnormality here? Patient had diplopia and proptosis for 10 years. Finally decided to find out what's going on. Anybody see any abnormality? Correct. As both Ben and Dan mentioned, there's erosion of the right anterior clinoid. Here's the left anterior clinoid we don't see, the right one. Anybody see what may be causing this erosion? Correct. As Dan said, an outline of an aneurysm. Notice the anterior clinoid over here. Notice that this is the undersurface has been eroded. All we see is the top of the clinoid. And here's some more views. This is a CTA again showing a large aneurysm that eroded the clinoid. And we can see it better on this coronal MR. Here's the large aneurysm. So this is an aneurysm involving the orbital apex. And here's another case of an aneurysm eroded the undersurface of the clinoid. Here it is on the axial plane. We can see it, the aneurysm on the MR. And here on the coronal CTA, notice that the undersurface of the clinoid has been eroded here, better seen on the axial. So now, aneurysm in the region of the orbital apex are difficult aneurysms because the issue is the aneurysm in the subarachnoid space, is it within the cavernous sinus? Because it makes a difference. If it's within the subarachnoid blade, then either it's bled or will likely bleed, and if it's within the cavernous sinus, it'll just cause cranial nerve sign as it expands or compresses the nerve. One of the helpful signs to differentiate, like here the three aneurysms, is the ophthalmic artery, which we can see here coming off the carotid. That helps us in most cases determine where the paraclinoid aneurysm, or as known before as ophthalmic artery aneurysms. So let's just again look at these anatomic specimens. As we look from above, the slide that I showed before, these are the two carotid arteries coming out of the cavernous sinus, which is below them. This one gives off the superior apophyseal artery. Again, the diaphragm sella is here, the two clinoids. That's why they're called paraclinoid aneurysm. Again, these are the two optic nerves. This is the ophthalmic artery, which comes off the carotid as it exits from the cavernous sinus and then goes into the optic canal. So we're talking about aneurysms of the carotid or the junction of the carotid of the ophthalmic artery. So this helps to understand how to separate intradural subarachnoid aneurysm, which could cause subarachnoid bleed, versus extradural, or what's also intracavernous. If we look at the sagittal image of the entire dissected carotid siphon, so here again is the carotid coming up into the cavernous sinus from the temporal bone. This is all within the cavernous sinus. Then it makes an anterior bend coming out of the roof of the cavernous sinus. It gives off the ophthalmic artery. Although this can be a little bit variable, it's still a good landmark as to where this subarachnoid space begins. So the position of the origin of the ophthalmic is a good indicator. So if we look again here, we can see that this aneurysm is really above the ophthalmic and is within the subarachnoid space. Here we see it's again, the dome is above the subarachnoid space, but where the base is really hard to say. And this is really below the ophthalmic artery within the cavernous sinus and unlikely to bleed unless the dome pushes up above the roof of the cavernous sinus. So although it's helpful, it's not always perfect. So people have looked at other ways to determine where the aneurysms are within or without outside the cavernous sinus. Here's an aneurysm seen on the MR, coronal MR. So normally, as I pointed out, this is within the subarachnoid space. This is above where the artery exited from the cavernous sinus, where the ophthalmic comes off, and this is within the cavernous sinus, this loop. And we can see the two loops normally here. Here's the one within the cavernous sinus, and here's the one above it within the subarachnoid space. Here's an aneurysm, and it's hard to say, is this attached to this, or is it within the cavernous sinus and projecting up a little bit? Will it bleed into the subarachnoid space, or will it just cause problems within the cavernous sinus? So MR has not been that helpful most of the time to detect where exactly the aneurysms are. However, the optic strut can be helpful as a landmark. Again, as I showed here on the CT, here's the ophthalmic artery, and this is the optic strut below it. Again, optic strut on this specimen. This is the clinoid over here. So again, if we look at this specimen, optic nerve, ophthalmic artery, so the floor of the optic canal is the optic strut over here. Now, can we use that to help us with aneurysms? Turns out that people have been using it. This is an article from neurosurgery where they use the position of the optic strut to determine if they could clip the aneurysm or not. So here the aneurysm, it wasn't clear exactly where it was in relationship to the structures. So here on coronal CT, we can see the clinoid. Here's the optic strut, and this was the neck of the aneurysm. So they knew they could clip right over here because it was all within the subarachnoid space because it was above the optic strut. Here was another case they did. They weren't sure exactly where the relationship of this aneurysm was to the top of the cavernous sinus, and on CT they showed that the neck of the aneurysm was proximal to the optic strut. So this was a purely intracavernous sinus aneurysm. It would not bleed into the subarachnoid space. And here's a case that of one of our CTAs that I found. And so here we have a small aneurysm, and we can see how the CT anatomy helps here, because here's the optic strut on the coronal plane, clinoid, the two optic struts, and we can see that this aneurysm is above the strut, so it's within the subarachnoid space. And here on the axial plane, this is the level of the optic strut. Here's a little bone of the optic strut, and here's the aneurysm on a slice above it. We can see the ophthalmic artery faintly here. So this aneurysm is really above the cavernous sinus and would be within the subarachnoid space if it bled. So CTA can be helpful when you identify the optic strut to tell of these paraclinoid aneurysm. Are they within the subarachnoid space, or are they within the cavernous sinus, or sitting right half in, half out? Okay, let's move on now to the ophthalmic nerve. First division of the trigeminal. The many branches of the ophthalmic nerve, I'm just going to focus on the frontal nerve at the first part of this talk. The main branches of the frontal nerve, which is, again, the main branch of the ophthalmic nerve, are the supraorbital and the supratrochlear nerves, which we can see outlined here on this beautiful picture by Netter. Okay, here we have a lesion. What is this lesion? Somebody mentioned meningioma, not a bad possibility. Anything else? Yes? Asif mentioned schwannoma. That's a good call. I want to again remind you of the anatomy here. Optic nerve going into the orbit. Anterior clinoid. This little notch here, that's the superior orbital fissure. Optic canal on the CT. Here is the clinoid. This little notch is the superior orbital fissure. Here on this beautiful specimen, optic nerve, chiasm, anterior clinoid with a marrow within it. This is the little notch for the superior orbital fissure. So if we now go back to this case, here's that little tumor going through the superior orbital fissure. Right over here, it would be sitting right over here. And this was a schwannoma. And again, if we look at this picture from Netter, here's the ophthalmic nerve giving up the frontal nerve with its branches. So here's the opening of the superior orbital fissure. And this is where the tumor was sitting. So it makes sense that it was coming off the ophthalmic or the frontal division. So this was an ophthalmic nerve schwannoma. Again, this little bit of it helps make the diagnosis, or at least think that it could be a schwannoma, because it's invading the superior orbital fissure. What's the abnormality here? A different case. Correct. What is involved here? What structure? What site is the lesion? Correct. As Ben and Matt said, there's enhancement of the supraorbital nerve. So here it is. It wasn't enhancement, it was just high signal on the T2. But here it is enhancing post-contrast images. So this is involvement. So again, if we look here, this is the frontal nerve, and these are the supratrochlear and the supraorbital nerve. Normally, these nerves are very thin and tiny on the sagittal view. But notice you can see nicely on the coronal images, here's the nerve, the supraorbital nerve, because it's more medial, and we can actually follow it anteriorly until it exits, as you can see on the skull. This is the supraorbital notch, or the supraorbital foramen, where the nerve comes out. You can see over here. So here again, this was a supraorbital nerve. It was likely a nerve sheath tumor, and we can see again in the normal the precise location where this nerve would be sitting. Here's a patient with herpes, and again we see the marked involvement here, the enhancement around the optic nerve, enhancement within the orbit, but also there was involvement of the supraorbital nerve. Here we see a large lesion involving the supraorbital nerve on the right side. There was also another mass here. What is the possible diagnosis? Two lesions so far. Correct. As Daniel said, NF. Notice the enhancement of this mass, enhancement of the supraorbital nerve. This was a plexiform neurofibroma in an NF case. And again, supraorbital nerve. This was just a mass in the orbit. Again, you can see on this specimen, here are the supraorbital nerves. And this is that enlarged one. This was another case of a frontal nerve schwannoma. Again, you can see the normal nerve here. What is the abnormality on this patient? Anybody? Big nerve, as Dan says, correct. Notice this big sausage here. This is all abnormal. Notice the normal size here, very tiny nerve. This is a markedly enlarged supraorbital nerve. Here's more of its component. This was a large cystic component further back. Here it is on T2. This was more anteriorly, high signal. This is further back where this lesion was. Here it is on coronal images, and on axial you see this very large lesion. Enhanced, there was an enhanced part. This was likely a nerve sheath tumor. This patient has been followed for at least 5 years. It's had multiple MRs and has not changed in size. So we have to presume that this is a nerve sheath tumor involving the frontal nerve and an extended portion of it. Interesting enough, a similar case is also published in the literature where they also felt was a likely nerve sheath tumor. Again, notice there was a cystic component, an enhancing component, and also kind of involved the entire supraorbital nerve on the sagittal plane here, and we can see the mass similar to our case. So this was a schwannoma, likely a nerve sheath tumor. Patient presented with trigeminal numbness, lesion here. Here it is on T2, enhancing. What's the, why am I showing the axial CT? Bone erosion, as Ben says, correct. This is the normal superior orbital fissure. This is a massively enlarged superior orbital fissure. And we can see there a large deformity here of loss of the anterior wall of the middle fossa, classic sign, expansion of the superior orbital fissure. This is a patient with NF1 with a frontal nerve tumor, which actually was resected. And this is a follow-up study, but again, the findings are still here. And this is another case of this from the literature showing again this expansion of the superior orbital fissure. And this was a plexiform neurofibroma, extending all the way from the orbit back to this markedly enlarged superior orbital fissure. Patient was NF1. Okay, now let's move to the last section about perineural spread, which really, you will see in my other lectures, involves all the divisions of the trigeminal nerve. Now, there are different kind of head and neck tumor. There are different way of spreading. You can have direct extension. You can have spread along meningeal surfaces, either the pachymeninges or leptomeninges. Then you have perineural spread and endoneural spread. That's what I wanted to focus on. What's the difference between perineural tumor and perineural spread? Perineural tumor is tumor around the nerve which will compress it, invade it, or may involve the meninges, but perineural spread is specific tumor that spreads along a nerve. There's also, some people distinguish between perineural and endoneural spread. That has to do with the layers involved. If we look, the different layers around the nerve. There's the endoneurium, which is surrounds individual fibers. Each fiber has a little layer of endoneurium, loose connective. Then there's perineurium, which are circular fibers and endothelial cells surround nerve bundles or fascicle. Those are the more important ones. And then there's epineurium, a loose around the entire bundle. Perineural spread tends to be the more malignant. Squamous cell, adenocystic, lymphoma, melanoma, very rarely meningioma will travel in the perineural sprays. Endoneural is the more slow-growing, more benign lesion like neurofibromas, schwannomas, and meningiomas. What happens with perineural spread? The cancer cell invade the perineural space and use it as a conduit for spread. This process causes myelin degeneration and segmental infarction of the nerve bundle, likely secondary to hypoxia caused by the compression. The perineural lymphatics are very unlikely to be involved, thus direct spread is not likely. What the etiology is unclear. Some people feel there may be a growth factor, which is also used by the Schwann cells and is present sometimes in large amounts in the adenocystic, which are notorious for perineural spread. Now, diagnosis is usually the nerve will be thickened and enhanced. There's loss of surrounding fat. There may be expansion or erosion of the skull base foramina. They usually skip areas, which is a serious problem. And there's early expansion, enhancement of the affected muscle, and eventually you get denervation atrophy. It's a very serious disease because it's really not curable except for massive excision of the involved nerve and the structures around it. It may be insidious, the symptoms, for many years after the original tumor. Early symptoms are often people describe like crawling ants or worms under the skin. Later on, there's pain, numbness, and motor deficits. The differential diagnosis is quite difficult because there's also normal prominent perineural vascular plexus. Infections may mimic it. Inflammations like Lyme, sarcoid, syphilis may mimic it, and also meningeal carcinomatosis. And also tumor around the nerve. So it's hard sometimes to distinguish the diagnosis, which is very important to make. And one thing is, you've got to know the full course of the nerve, all the way from the nucleus to the innervation site, because that's how you will pick up these very difficult and important lesions. Now, the nerves, the divisions of the ophthalmic nerve, which are important to make the diagnosis for that, are the following: the supraorbital nerve, the supratrochlear nerve, and they're extensions to supply the forehead and the nose. And those are the branches coming off the infratrochlear nerve and the cutaneous branches of the lacrimal bud, and then there's some nasal branches from the ethmoidal. So all these nerves within the orbit continue on the surface of the skull, and that's an important issue here. What's the abnormality in this case? Correct. As Asif says, look at this thick enlargement of the frontal nerve. But look what you see here. You see enhancement, and you see all this enhancement all the way to the cavernous sinus. This is a classic case. This patient had a squamous cell carcinoma of the forehead, and then sometime later had perineural spread. So from the tumor being over here, here it is, it's now spread all along the ophthalmic nerve, the frontal division, all the way back to the superior orbital fissure, just like in this diagram. So this is perineural spread of a squamous of the forehead along the supraorbital nerve, the frontal nerve, the ophthalmic nerve, all the way into the cavernous sinus, in the inoperable situation. Here's another case showing signal in the upper part of the orbit, and here it is. This was a squamous carcinoma of the forehead. Again, perineural spread from the forehead all the way back to the superior orbital fissure region. Here's a patient, not a very nice image. What do we see? There's been exoneration here, but notice a mass in the prepontine cistern here. This was a malignant nerve sheath tumor of the forehead many years ago. I think it was about 10 years ago. Now the patient presented with symptoms again. And notice that the mass here and the enlargement of the cavernous sinus. So again, whatever the tumor, the malignant tumor of the orbit, has traveled now along the of V1 fibers all the way back to the prepontine cistern and the cavernous sinus. Here we see a mass in the region of the frontal nerve. Here it is, enhancing. This patient had a facial skin squamous, and presented about a year later was V1 distribution numbness. And what has happened here? So first of all, the supraorbital nerve is involved, enlarged. But notice, on the axial view, we can see enhancement further back. And look at what has happened further back at the level of the cavernous sinus, enhancement, expansion of the cavernous sinus, and prepontine tumor. Again, this forehead lesion, perineural spread along the frontal nerve, the supraorbital nerve, frontal nerve, all the way back into Meckel's cave, cavernous sinus, and the prepontine cistern. Again, inoperable. And here it is on a sagittal view. We can see the thickening here on the T2. Here's the enhancement of the frontal supraorbital nerve here, all the way back, and this is the trigeminal in the prepontine cistern. You can see right in front of the cerebellum, the pons here, the middle cerebellar peduncle, this whole area's perineural spread from the forehead back. And again, on the coronal, you can see the involvement in the supraorbital nerve region, back, in the region of the superior orbital fissure, orbital apex, cavernous sinus, all the way even down to the foramen ovale region. And we can see here the enhancement of the coronal of the cisternal portion of the trigeminal nerve. And this is the last case I'm showing today. Thank you for your attention. And next week we'll proceed to the maxillary nerve, which is complex with many abnormalities to point out.